I'd like to invite Charles Hugh-Jones to step to the podium. He'll be talking about the concept of data sharing among companies, among trials, which could allow us to perform much more powerful analyses from the data that's already been collected. Charles?
Great. Thank you very much, Mace. Thank you, Chris. Thank you, Marty. Thank you, Bob. So I want to spend about 15 minutes talking about this concept of clinical trial data sharing. And really that is about using all the raw data that we have sitting in our warehouses, whether it be corporate, whether it be academic, to use that for secondary research to ultimately benefit patients, both with cancer and potentially with other diseases. Now, you may remember this time last year at the CEO Roundtable, I proposed on behalf of Sanofi Oncology the donation of 2 phase 3 pivotal trial data sets, the comparator arms of those, as almost primers to start looking at this question of donating data. And in the spirit of the fact that no good idea goes unpunished, we spent the last 10 months or so looking at the feasibility from an ethical, from a legal point of view of actually doing this. And I think if I'd suggested to my team they had a chance of solving world peace or how to solve data sharing, I think they might have gone for world peace. But we've made some good progress. It was a great idea, and I think we have looked at some ways of making it happen. Now, there's a huge amount of literature out there, and that really talks to some of the problems that we have with this concept of data sharing. And they fall into 4 major categories. One is the ethical issues. The second one is the legal issues. The third are the technological issues. And the fourth are social issues. On the ethical side, it's really about the very fact that sharing data is using data for what it was not originally intended for. And did the person that give consent for that original trial, are they happy for their data to be used for that purpose? On a legal side, it's then a continuation of that ethical issue of how do you actually de-identify that data at the same time that from a clinical perspective, you maintain the integrity of the data enough so that it's actually useful for doing secondary research. And in fact, in this period of information technology, how can you really actually ensure that you can de-identify this data properly anyway? On a technological side, it's really a matter of once we get all these data sets together, how can we actually make sure that they talk to each other? So rather than doing ad hoc analysis, which is good, but not as good as it could be, how can we start producing aggregated data sets? And I'm going to talk a little bit about data standards. And then on the social side, this is an interesting question. We often work in an environment, and this is probably more academic than corporate, where the whole social structure is based about you not sharing data. It's about the fact that you get grants for publishing and doing secondary analysis. And so there is actually an institutional barrier for doing this sort of data sharing. So we put together a project team. We had bi-weekly meetings. We did an extensive literature search. We looked at a lot of the analogues. We had extensive stakeholder discussions, both with governmental and non-governmental organizations. And then we put together 3 work streams, one with which was clinical, looking at the de-identification of this data. The second was an IT work stream, and we ran a pilot here with SAS last summer. They very kindly provided the resources for that. And then we had a legal work stream that's been really working very hard to address some of these IP, antitrust, privacy concerns, and so on, which finalized with a summit of the various different life sciences consortium companies in January of this year. And I think we've come to some sort of resolution about how we can move forward. So I want to show you a few slides over the next 10 minutes that summarize where we're at with this particular project. So I think our working premise is the fact that oncology is at a crossroads in terms of research. The graph you see up here shows the mortality per 100,000 population over the last 30 years for cardiovascular patients. And what you see is our colleagues in cardiovascular have done a very nice job in halving the mortality over the last 30 years. We then superimpose on top of that what's happened in cancer, and for no fault of anyone, and there are very good reasons for this in terms of the heterogeneity of the tumor type and so on, the fact is there has not been that much difference in overall mortality per 100,000 population in the last 30 years. And in fact, even the delta you see around 1991 is to a large part caused by non-pharmaceutical interventions like colonoscopy, changes in smoking habits, which talks well to what we're doing with the gold standard, PSA screening, and so on. So whilst there are very good reasons for this biologically, we have to take this as a fact. And what can we do to solve this problem? Well, there are many solutions, lots of things are ongoing, but one of them, I think, could be data sharing. And I think as a project team, we were excited early on that there is agreement from both a federal level and from an academic level that opening up drug data is a good thing. That what you see on the top left here is a comment by Peggy Hamburg back in December of last year, looking at seeing the huge opportunities in opening up drug data. And here she's talking specifically about regulators and drug makers. What you see on the bottom right, is Dan Haller and his group at the JCO really looking to ask us, as an industry, to show us the data. What it doesn't say is how you should do it. So there have been multiple attempts at promoting data sharing over the year, and I think the very fact that there is so much literature out there speaks to not only the interest, but also the challenges of doing so. So there are piles and piles of papers that we've looked through. They fall predominantly into two major categories. One category that's looking at some of the technological ways of doing it, some of the ethical issues and so on, and there's reams and reams of papers there. The second is bemoaning the fact that it's not happening. There have been multiple networks set up, mainly federally or in quasi-governmental organizations. You may be familiar with the Cancer Bioinformatics Grid. Another organization as part of the Critical Path Institute, the CAMD, Campaign Against Major Diseases. We've spent a lot of time speaking with them over the last year about a project that they did, not in cancer, but with Alzheimer's disease and Parkinson's disease in terms of creating a data sharing integrated databases. But there are obviously challenges in the differences between Alzheimer's and cancer. And then there's been policy initiatives, and many of you will know that federally funded, or in Europe, other organizations such as the Wellcome Trust have built into their policies that those people receiving this sort of type of public funding should be having a data sharing plan as part of their research. But what was interesting is that when two people called Savage and Vickers is out of Memorial Sloan Kettering, made an active attempt to ask those people who had the funding that declared that they should be sharing the data, they got less than 10% of people prepared to share the data. So there's obviously a problem. So we then started looking at the benefits, and I think there's no doubt in everyone's mind that the benefits are there for doing faster, cheaper, more efficient research, whether that be in terms of methodology, smaller trials, maybe bulking out comparator trial data sets with all this data that you can collect, running secondary hypotheses, epidemiology, and so on. The second big issue is that of data standards. And talking to our friends at CDISC over the last few months, they said data standards are a little bit like green vegetables. Everyone knows they're good for you, but no one wants to have them. What really data standards mean is that, here's an analogy, is that you can go to a mobile ATM in Thailand with your Wells Fargo credit card, and you can pop your card in, and you can get $100 out. And what's extraordinary is all the banks, and for that matter, given this is a mobile ATM, all the telephone companies manage to get together in the pre-competitive space and work out data standards that allow you to get that money out, even though you've come all the way from America and they don't know you from Adam. So it's going to be incumbent upon us more and more as we get towards into PDUFA 5 that we create PDUFA standards. What CDISC want from us is to be able to look at all this data and use it to work out standards. So they're prepared to help us if we can help them, and that's a dialogue we've been having with them over the last few months. And I think finally are the things called what I would call, in sort of Rumsfeld fashion, the unknowns. We don't know how people could use this data, but I think there are all sorts of potential ways that it could be used. The challenges we address were those of a sponsor. And I think our general feeling was that from an intellectual property, antitrust, or a competition law in the EU, mechanistic resources and incentives, these were all things that could be achieved to some extent with the necessary resources. But we focused a lot of our time on how do you share data within the context of a privacy, confidentiality, consent, and ethics point of view, and that's what affects the patients. So from a patient privacy framework, the legal framework is that of HIPAA, which is 1996, which bars covered entities, which pharmaceuticals are not, from sharing records for secondary research without consent. But what it does allow us to do is to de-identify that data. And if we de-identify it, then it stops being protected health information and we can share it in a database. The second is the common rule, which came out of the Belmont report and also the Nuremberg trials, that allows for informed consent required for trial participation. And this really covers not only physical risk when you join a trial, are you going to be in any way damaged physically, but also informational risk. What happens when health information about you gets shared with people you don't necessarily want it to be shared with, whether it be insurers, whether it be your employer, and so on. But again, within that rule, de-identification does permit data sharing in the absence of explicit consent. There's also, and this really is the sort of top line cliff notes, but there is a lot of inconsistency between these two rules that we've worked our way through, and there are some more changes coming as an advance notice of proposed rulemaking from HHS later in this year. And then finally, in the EU, which is obviously a hotbed of data privacy, we believe that, again, anonymization does allow us to data share, and we believe we can get around some of the cross-border transfer of records by using our corporate standing rules. So, what do I mean by de-identification? We have these huge data sets, and there are two ways we can prevent make people feel comfortable that it's been adequately de-identified. The first is to scrub 18 identifiers out of this data. That's everything from name to address to your driving license to where you live and so on. The problem with that for us as scientists is once you start scrubbing out too much data, it stops actually becoming useful. We need these time-dependent endpoints so you can actually run time-dependent analysis. It's probably less critical for epidemiologists, but they also want to know things like address or the state in which you live. So the alternative way to de-identify the data is to scrub lots of the identifiers, but not all 18 of them, and then to get a statistician to define that the chance of re-identification is what's called low. Not defined, but it's reasonably low. And we feel that if we hold this data as a life sciences consortium or through a third party within what you call a quasi-protected database where you have to have criteria in which to go in, I think we can satisfy the de-identification criteria. So, two paths forward. For our retrospective studies, we de-identify it and use our corporate rules, and then we proceed. Prospectively, we would like to work as a life sciences consortium to look at how we update our HIPAA authorization, how we update our informed consent templates for secondary research, and use that as a way of bolstering the credibility of the data going forward. So the achievements so far, really just to summarize, the project team met on a very frequent basis to discuss these issues. We did these extensive literature searches. We're going to publish what we've done in the last 12 months. Marty's very kindly offered the oncologist as an outlet for that, provided we hit his publication standards. We've had regular partner meetings, and we've got a whole lot more coming up because I think there are still critical issues to discuss. Our IT work stream ran a secure data pilot here with SAS over last summer. We're now scoping out what exactly this database should look like from an IT perspective now that we've solved a lot of the legal issues. On a clinical side, we've looked at different ways of cleaning the data, preliminarily de-identifying the data, but making sure that we make it workable and usable for the sort of people that might want to use some of this data, whether it be academics, whether it be corporate researchers, and so on. And then finally, the legal work stream has done a whole host of work, and I'm very indebted to John and to Anne for all their hard work in pulling together external counsel, looking at antitrust issues, and organizing the summit we had earlier this year. So really just some final considerations around this. I think we have to decide as a life sciences consortium whether this needs to be just a simple file sharing, or do we move towards a more sophisticated, integrated database where we start to come up with disease modeling. Again, should it be something that we do, or is it something that a third party should hold? And should we work with federal colleagues to find a way forward here? I think we've made a good decision that we're going to provide the comparator arm data. There's obviously resistance amongst certain companies for very good reasons at providing the active arm as well. We would provide the CRF data descriptors and so on, but not the statistical analyses plan. And I think we're pretty comfortable that from an intellectual property point of view, most companies, based on the analysis we've done, should feel comfortable in donating data to this sort of database. So our long-term implementation plan is we've done the pilot, we're going to release the data over the next 6 to 9 months, as is in a sort of file share basis. So anyone that goes in is just going to get the raw data unstructured. But then we're going to use the time ahead of that, whilst people can do their own ad hoc analysis, to work with CDISC, work with HL7, ISO, and so on, to put disease-specific standards in place. And in fact, CDISC are having a teleconference this morning with Janet Woodcock about this very specific issue. And then also work with SAS and our other colleagues in terms of defining the IT framework. And I think what it'll allow us to do in the long term is to form an integrated database where we can start building some disease-specific models to move forward with this. And I think that's going to be more useful than the ad hoc analysis, but it's going to need those standards in place. So next step, 6 months, we've summarized the legal risk. We need to get the framework in place. We're going to work closely with a large number of stakeholders, publish our progress, and then define our future resources. And then really, it's over to the other companies within the Life Sciences Consortium. I think we feel comfortable from Sanofi that we can do this. We're going to run it out over the next 9 months. I would ask the other members that we get a commitment to data sharing. I think it's critical that we can start to bend that curve for our oncology progress. I'd ask each of you to start exploring company-unique data sharing plans. We're more than happy to share our experience that we've had from Sanofi. Explore consent modification. There are obviously going to be challenges there in the short term with bias associated with modified consent. Public education, and then this real 1,000-pound gorilla in the room, which I think we have to solve, is how do we provide the active arm data as well as the comparator data. So I'm going to finish there. I just want to say thank you to a lot of people who put a work into this. It's been on top of their daytime jobs. I'm very grateful to Anne, to John Dornan, who's not here, to Marty as well, for all their support with this, and Debashish for sponsoring the project. Thank you very much.
So 5 more minutes.
We have 5 more minutes? Yeah. Okay. The agenda's been shifted a little bit, and Liz Fowler will be calling in about 5 minutes, so we'll be able to hear her at that time, so we're not missing anything. So Marty tells me we've got about 5 minutes for questions on both topics, so already hands are going up. Yes?
Great presentation. Just a question about others that could participate in the data sharing. Would you see that, for example, say the Department of Veterans Affairs or the Department of Defense or somebody like Kaiser Permanente that have these systems that have large databases could join and participate in something like this?
Yeah, no, absolutely. I think the goal is as many people as possible that can contribute to this, the richer the data set becomes. So absolutely.
Yes, Derek?
Charles, that was very interesting. I wonder if your committee has thought about creating a concept of time-dependent scrubbing. So rather than taking tax 327, which is relatively recent information, whether it might be worth thinking about getting old breast or lung or prostate studies, and I'd define in this context old as being more than 10 years out of date. And so the reason that would be attractive is you could scrub the data at the point of 10-year follow-up. It would be less sensitive at a corporate level, and you could actually model the data sharing with a good period of follow-up. There would be less corporate sensitivity, and then having demonstrated that the model worked and the extent of utility of the data, then you could start with that group that already had a sense of corporate integrity to start to do things more recently. So I wondered if you'd thought about doing it that way, and in that sense, you would avoid a lot of the issues that related to de-identification because you'd actually have the data de-identified linked to 10-year follow-up. 10 years probably for most of the cancers with advanced disease that we treat would be enough for most of the projects that you might want to do.
Yeah, no, I think that's a great idea. I think part of the challenge has been actually accessing some of the data, pulling it together. We've started just with these 2 data sets to look at the feasibility, but I think going forward, going both not only prospectively but retrospectively is a very good idea, and I think it's certainly something we would consider.
Yes.
Felicia Null, Harvard Global Equity Initiative. Agreed, phenomenal presentation and a super idea. Just two thoughts. One is, having just been last week at the inaugural meeting of the Global Center for Cancer at the NCI that Harold Varmus is putting together, I think this could be of enormous interest. And so Ted Trimble could make tremendous use out of the products that are coming out of this if it includes global data. And the other is that thinking a little bit about an earlier comment in the first session on the importance of understanding delivery. If we're thinking about going global in settings where delivery is one of the barriers, it would be extremely interesting if the data set could also include some implementation research in addition to the clinical studies.
No, I think that, again, very fair comments. And I think as we have these discussions, I think what's happened at this stage, it's been a lot of us trying to work out exactly how we're going to do this. And I think as we now have synthesized our thoughts into the best way forward, and it's taken quite a long time to do that, I think we now need to be reaching out to the NCI, to FDA, and so on, and having those sort of discussions. And I think having solved this legal issue, which has been circulating around us for the last six to 9 months, I think having solved that, I think absolutely those sort of discussions are a really good thing to have in terms of that implementation. Thank you.
Charles, could you just make one additional comment? Does it raise legal questions, and with regards to the government?
You mean having the government involved, Charles? I think that what we're trying to do, honestly, Charlie, is to create a means of sharing it in a way that is both clearly in pre-competitive space, in other words, not sharing information that would be used to advantage the companies who are doing the research, going forward. But secondly, to try to find a way that would allow this to be open to, as was already mentioned, data from other sources as well. This is not meant to be just a manufacturer database.
No, absolutely. The broader this can be, the better. And I think part of publishing what we're doing, having dialogue with both federal and corporate entities, is about transparency. And I think it's critical to the initiative that we're transparent about it from the start.
Cheryl?
So in one of your first slides, you showed a lot of the key stakeholders in this space. And I would encourage you to add the Institute of Medicine under the policy column, because the Institute of Medicine has a long history of addressing these sorts of issues from legal, ethical, technical, cultural perspective, and have made a lot of recommendations.
No, you're absolutely right. A lot of our thinking has actually come from IOM documents, and I appreciate that.
Rich?
I'm delighted to see that this is more than 20,000 individual cases, and has led to a number of different papers. We've recently tried to mount a similar effort in metastatic colon cancer, and recently published a letter in the Oncologist inviting external people to apply to use the data. Dan Sargent has been the statistician that led this, and has blazed this trail, and probably would be valuable to you in terms of figuring out what the common data elements are that you want, what is worth putting into the database and what is not. One of the issues that we've dealt with is the fact that many of these studies were done on drugs that turned out not to be priorities for the companies involved, and they're reluctant to continue to spend money on massaging the databases in a circumstance where there's no direct return on investment. And then finally, I would say that there's a lot of expertise in academic centers and elsewhere for the use of this data, and that you want to have some sort of process for external individuals applying to use the database as you put it together.
Marty?
Maybe perhaps, Rich, you might want to continue that commentary by sharing what actually Amory de Gramont and Dan Sargent were able to do with a retrospective analysis in terms of GI cancer, which, when brought before the FDA, reduced actually the indication from 5 to 3 years.
So what we did with this was to look at databases and pool about 14,000 patients worth of information. And the long and short of it was that we were able to establish that 3-year disease-free survival was very strongly predictive of overall survival, allowing the turnaround time for adjuvant trials in colon cancer to be shortened dramatically from 5 to 6 years of follow-up to 3 years of follow-up when reporting. And that actually led to the licensing to the indication of for oxaliplatin in stage 3 colon cancer being accepted sooner than it might have been, getting an advance to patients more quickly.
So there is an example, isn't there, Rich, of a direct patient impact by taking advantage of this enormous font of data, properly analyzed and generously but prudently and legally shared, that then could derive information that the FDA would then take, and which ultimately ended up in speedier drug approvals. Hence, the wheel goes round and more patients were benefited, Mace.